Okay, begin.
Good morning, everyone, and welcome to this very timely discussion on the NHS People Plan, and thank every one of you for joining us today. As you'll know, and you too well, the workforce shortage across the UK's health and social care sectors is one of the long-term challenges facing the NHS and providers of NHS services. And whilst the COVID-19 pandemic has changed the reality of work for all health employees, it has also created a new and strong interest in careers in these sectors. This presents policy and industry leaders with a unique challenge and opportunity to fill some of the NHS's vacant posts and deliver on the objectives of the NHS People Plan, all with the aim to continue to improve NH services on the ground. So it's wonderful you're all here today. The format is very briefly that we have panellists, and I'm going to ask them to introduce themselves because you've already seen the summaries of their biographies, very impressive too, on the programmes. And then there are going to be 4 preset questions, which I will read out when we get to them, which they're going to answer and give us the benefit of their wisdom. And then we'll open up for a general Q&A session for participants who'd like to raise any particular issues. And the organisers are going to help us organise that because that's quite challenging. So I'm going to begin by introducing myself very briefly. And all I have to say about myself is I'm actually a nurse and a social scientist by intention, that's what I was, and a baroness by astonishment. I wasn't into politics, I don't like politics, and I was so much not into politics that I was the first baroness I'd ever met. I didn't move in those circles. You wake up one morning and you find a baroness looking at herself out of the bathroom mirror, and it's quite a shock. But of course, it's a huge privilege to be able to speak in the House of Lords, which is what happens when you become a baroness. So I thought I had best to use that opportunity to speak in Parliament. And the idea came very clearly that it's a wonderful place to be a voice for those who don't have a voice or people who have voices which are not heard. And so a lot of my time now is spent abroad because I established a small NGO, Heart Humanitarian Aid Relief Trust, to work with local partners. We work with them. They're the leaders in their own communities. And they're in war and conflict areas not reached by other aid organizations for political or security reasons. So a lot of my time now is with partners in conflict areas such as Syria, Nigeria, Sudan, Burma, Burma because locally we prefer that to Myanmar, etc. But I still have a deep, deep commitment to nursing. I think it's a wonderful, wonderful profession. And so I greatly look forward to this important event with such well-informed speakers. And as I say, I'll be asking each of you if you'll introduce yourselves on your own terms, and then we'll go to the 4 preset questions and then open up for a general question and answer. So thank you all for being here. And it's such an important time to share these concerns. So the panelists who might like to introduce themselves, and then we'll go to the questions, whatever order you like. Should I suggest Chris, Sam, Finn, and Mike? Chris, like to introduce yourself.
Good morning, everyone. I'm Chris. I am a senior fellow at the Institute for Public Policy Research. So we are, for those that don't know us, the spiel is the UK's preeminent progressive think tank, and I lead our work on health and on social care, which is one of our biggest programs of research. Excited to be talking to you today, and with such esteemed other speakers. I'll leave it there because you can go on too long on these things.
Thanks a lot, Chris. Sam, would you like to come next?
Thank you. Good morning, everybody. My name is Samantha Kane. I'm the Chief People Officer here at Virgin Care. We work in partnership with the NHS and local authorities up and down the country, delivering NHS services in a range of forms. We are passionate about transforming health and care services to benefit and drive greater outcomes for patients and service users. And I'm incredibly excited and passionate about the people agenda. So very much looking forward to our discussions this morning.
Thank you so much, Sam. Finn, would you like to introduce yourself?
Thank you, Baroness Cox. Hi, everyone. My name's Finn O'Dwyer-Cunliffe. I'm the Workforce Policy Lead at NHS Providers. For those of you who don't know about NHS Providers, we represent all 215 at last count NHS Trust and Foundation Trust as their representative body, primarily a sort of lobbying support group. We are happy, again, as others have said, to be amongst esteemed speakers and looking forward to getting into the discussion about all things people plan and NHS workforce.
Wonderful. Thank you so much. And last but by no means least, Mike.
Thank you. Good morning, everyone. My name is Mike Adams, and I'm the Director for England at the Royal College of Nursing. Been in the role, starting the role at January 2020, and prior to that, I'd worked for the RCN in the West Midlands before that, and I'd worked then for several years in higher education, in nurse education, so a nurse by background. And yeah, I'm really looking forward to the conversation. You will have heard a lot of us as a college talking a lot about people and the importance to be looking after our people in order to retain them. So I'm really looking forward to the conversation. Thank you.
Well, aren't we fortunate to have such a wide range of expertise and knowledge joining us for this time together? So thank you for introducing yourselves, speakers. And these are questions being suggested that you answer. And the first one, for everyone's information, is we went into the NHS's most challenging year, the challenges around recruitment and retention. What was causing those challenges, and does the People Plan begin to address them? And Chris, would you like to kick off?
Thanks, Baroness Cox. Absolutely. So I think the temptation with a question like this is to start the response in COVID in March 2020. But I think it's very difficult to answer it without kind of thinking about the decade that preceded it. And I mean, I suppose I like to think about where we were in December 2019. That's quite a difficult thing to imagine. It was a very different time. We could go to the pub, we could go out to restaurants, I could get a haircut. That made my life immeasurably better. And I'm sure we can all reflect on what things look like 18 months ago. But actually the seeds at that point for what happened during COVID-19 had been sown in many places. At IPPR, we've looked across a whole range of metrics about what the UK looks like and what England specifically looks like as compared to other countries. And we see that in many cases, things are worse, but there's nowhere that's more true than in terms of workforce capacity when it comes to resilience sustainability. So if we're thinking about what that challenging year looks like, then we can reflect on the capacity difference in the UK health system as opposed to other comparable health systems. The numbers are quite shocking. There's lots, isn't there, of commentary around the kind of 40 to 50,000 nurses, the thousands of doctors, the thousands of other professionals that we're short. Our finding was that's just shortage. And in fact, if the UK was to try to get to the capacity that other health systems have, the kind of top quarter of the OECD, we're not talking thousands or tens of thousands of staff. We're talking 220,000 nurses. We're talking tens of thousands of practicing physicians. So a really big challenge. I think when we're thinking about why those shortages have occurred, we probably need to start by thinking about it as really the consequence of sequential pressure from the last 10 years. So essentially what's happened during particularly austerity has been that the experience of being employed and the offer of employment within the NHS and in social care has got worse. There are indicative policies that drive that. So we can reflect on the public sector pay freeze almost as a starting point, and an indicative policy in 2012 to 2017. So a massive deflation on pay, around 10 to 15% real terms cut for many, and as high as a 30% cut for some. And I suppose what you see is almost what I would like to talk about as a Python's grip. The experience of working in the NHS becomes worse, the pay becomes worse, the focus on efficiency and productivity creates new work. There's an edifice of extra work that people need to take on. And the wheel turns, you see that turn into stress, into burnout, into fiscal difficulties, particularly for those in bands 1 to 5. And in turn, people leave the sector. There's often a calculation, not just during austerity, but again taking place now, that labour market conditions during crises are such that people won't leave or people can't leave. And so the investment into the workforce doesn't need to be put in place. And what we see is that actually people in the NHS, they're hugely skilled and very attractive to other sectors, to other countries, and people do leave in quite large numbers. So what we get is a position where capacity drops, where the workforce numbers drop, where the share of workload that's left is distributed amongst an ever smaller number of people, and burnout increases, and so that cycle turns and we get quite a vicious circle. going into the pandemic, and we've seen the consequences of it. In terms of the People Plan and whether that begins to address some of these challenges, I think there's some good content. I think a national strategy that can give answers to some of the questions of stress and burnout that we see in staff surveys, that's good. And I think having a national approach has some benefits as well. But I think that needs to be countered and balanced against how many tools the People Plan lacks. So the things that are really important, I think, to recruitment, retention, there's really a holistic pattern and a package, and our polling indicates that 5 things are really important to anything that the government were to bring forward on this in terms of strategy. Health is one, so physical health, and that's probably a consequence of the pandemic, that when we ask in our research the workforce what they prioritise, that health has come up and physical health has come up very strongly. Mental health as something that when we ask the workforce, they say needs to go much further, and actually our results suggest mental health support more important even during the pandemic than physical health support. Pay comes through incredibly strongly for us, and so do welfare interventions, so childcare support and housing are things that we consistently see. And then rest and flexibility and the ability to have work-life balance. So some of those are things that the People Plan can address, but many of those things are levers that need to come from beyond the People Plan. Many of those things are things that need to go beyond the time horizon of the People Plan. I remember a lot of conversations in the development stage of that document that were debating whether it should be a 5-year or a 10-year strategy. In fact, it's neither. So some of those things need a longer term approach. And I think the final thing that the People Plan probably needs to reckon with is that the government's reform agenda more widely is moving towards integration. And it's very hard for a People Plan that comes out of the NHS to capture that same integration. So our research consistently shows that social care is a sector where things are bad in terms of pay, workforce satisfaction, recruitment, turnover, lots of worrying indicators. It's very difficult for a strategy that's only within the NHS to capture that and then to superimpose itself on that trajectory to integrated care. So I think there's some real challenges and some real areas to go further. I suppose the opportunity is that we're in a post-pandemic era. There's never been more focus on the workforce and the importance of the workforce in both health and social care. So there's public will for big policy change, for big political change. So that's the opportunity, and that's always good to end these kinds of responses on a positive note. But I think there's lots of work to do.
Thank you very much indeed. A superb opening. Does any of the other panelists like to take part? Sam, do you want to add to that? Don't have to, but if you want to.
No, I would echo the sentiment there of Chris. It's a hugely challenging agenda, and it's really important actually that we don't just focus on recruitment and retention for the reasons that Chris says. It's a real holistic, systematic approach that needs to touch on everything, and key for me is the individual's employer's responsibility in creating environments that enable people to thrive. This job will not get any easier. The environment will only get more complex post the pandemic and beyond, for the complexities again that Chris talked about in terms of our population and our health challenges. So we have got to find ways that continue to motivate, engage, stretch, develop, and offer real opportunity in the long term for these challenging but hugely rewarding careers. We have phenomenal people working in our NHS, and this year really highlighted it, but they've been doing it for years. And again, as Chris says, this is bigger as well than just health services. The broader care sector, social care services are equally important and equally under pressure too. So I think you're right, the People Plan helps shine a light, but we've got to do more, both as individual employers, but also across systems, because some of these will not be done on an individual basis. We have to work together.
Thanks very much, Sam. Finn, do you want to add your own wisdom to this?
Yeah, sure. We'll try wisdom if it comes out that way. But I think I would just I obviously agree with the previous two speakers, and particularly in putting the People Plan sort of in its correct context. I think Chris made the point that we'd talked about a 5-year plan, we talked about a 10-year plan, we talked about at some stage, perhaps the first sort of integrated workforce plan for health and social care in a generation or ever. I'm not old enough or actually from this country enough to know the answer to that. But what I would say is that there are lots of good, the People Plan is grounded in the right ambitions and the right values. And I think it focuses on some good areas that individual trusts and other employing organisations in the NHS can focus on. But it is ultimately a list of 100, 110, 120 actions for sort of employers that they can get on with or try and address in the shorter term, in the absence of a long-term plan and in the absence of long-term funding, which has been really sorely lacking for the workforce coming from the government in recent years. So, in order to make long-term changes and address those sort of priorities that Chris was talking about from their polling, we need to sort of move, whether it's the next iteration of the People Plan or whether it's sort of other strategies being developed by the government in consultation with the sector. We need to sort of be a bit bolder and think about what's really going to make the impact for our workforce in the longer term.
Thanks very much indeed for words of wisdom from all of you. Mike, anything you'd like to add from the RCM point of view?
Yeah, I mean, I think, largely that obviously we've been calling, alongside all the other unions, calling on a focus on staff and workforce issues for years. So this is definitely a step forward and focusing on obviously well-being and how do we treat people, how do we look after people in their workplace is core to what we are pushing for. What it doesn't still doesn't address is kind of a long-term workforce strategy, published workforce strategy of how we are going to recruit people into primarily the NHS, but obviously it's not just the NHS. It's the wider health and social care system that we know we talk about NHS vacancy rates because they're published, but the numbers of nurses and wider healthcare professionals that we need across the whole system is something really that we don't talk about enough, I don't think. But we know we use the data we have available. So we do need that kind of fully funded workforce plan to make sure we can invest in recruitment and retention, in training, in ensuring students feel supported as soon as they come into whatever profession that they're in, but from our point of view, nursing. And I think one of the areas we don't talk about enough in this discussion is actually about safety and what is safe. The original question is what happened kind of leading, were we at a point at the start of the pandemic that we're ready? And no, we hear stories all the time, we hear evidence all the time that our members do not feel safe in their work environments because there aren't enough people. And having enough people and pay are intrinsically linked, but also how people are treated in their workplace. So we're also pushing for some legal accountability around staffing levels, because those are the things that make people not want to be in their workplace, feeling professionally unsafe, and then also feeling valued through their pay. So People Plan definitely has lots of important elements about how we treat people, how we value people kind of personally and professionally, but we need a much stronger and more visible workforce plan that is a real clear path for how we get to where we need to keep people safe in their workplace, but also how we keep people safe that we're caring for.
Well, thank you very much. It's very, very insightful contributions, much appreciated. May I just make one personal suggestion, and that is these kind of conferences are superb at identifying problems and maybe indicating possible solutions. But I think it would be very helpful if towards the end, if it was felt appropriate by my professional colleagues, to suggest some action outcomes, if there's anything specific that might do collectively or our respective fields of work, actually to address some of the problems. I sit in Parliament, as you know, and you don't need to call me Baroness, by the way. I'm Caroline. I'm a nurse first and foremost. Baroness has got a sense of humour. But I use it, as I said, to be in Parliament, to be a voice for those who don't have a voice. But I was appalled and angered beyond description when I heard about the 1% pay increase. And I think that was an insult to professions which are really given beyond the call of duty through the hellish months that preceded this. So if there are any practical things you can suggest, and I'm a wider participant when it comes to Q&A, anyone got any suggestions, practical ones, for the very real problems we know are out there, and some suggestions have already been made, and I appreciate that. But I think it's quite good at the end of a very important conference like this, maybe to have some action outcomes as well, so that we feel that something's been achieved or can be moved towards achievement in practical terms. Just a little suggestion, which might not be appropriate, but I think it could be. I want to comment on that before I move on to the second question. No? Well, the second question is one of the People Plan's focuses is looking after its people through delivering health and well-being support. How can this be sufficiently met against the demands and nature of the job? Challenging one. Finn, would you like to kick off?
Sure thing. So I kind of interpret this question as to whether, given the demands and nature of NHS jobs and what the People Plan says, are we sufficiently able to look after their health and well-being? And the short answer is no, probably. The short answer is that we can't with the current nature of NHS jobs. The longer answer, there are positives through the People Plan. There is a good focus on health and well-being support. I'd be remiss not to mention that NHS England and Improvement, it did produce some really useful tools for staff and for trusts and other employing organisations in the NHS to use to help staff get through the pandemic. The sort of wellbeing toolkit and wellbeing online resources. Trusts have focused a lot, speaking more about trusts because those are our members and the organisations that I know about. So you have to forgive me there, but we had a poll at our virtual annual conference last year, showing that over 90% of organisations had introduced sort of bespoke wellbeing offers, new initiatives during the pandemic to respond to the impact that it was having on staff. So that's really positive as well. I think that there's other positive things in the People Plan, like normalising health and wellbeing conversations, through line managers, plenty of support, plenty of guidance and advice on how to improve management of staff at that sort of line management level, which sounds obvious, but it is really crucial because the NHS is 1.5 million staff. You need to get it right and have that wellbeing focus throughout the workforce. But I think these tools, while enabling a response or sort of enabling us to cope as a whole service or as a whole workforce for a short period of time, they don't really tackle the bigger problems. And we've already talked about some of them, but research is fairly well established that high levels of workload lead to stress at work, lead to burnout. And there's huge concern about burnout at the moment in the NHS. Another poll of ours showed 99% of trust leaders in October were concerned or very concerned about levels of burnout throughout the pandemic. 99% in any poll is pretty eye-opening. But I think the NHS staff survey came out last week as well, and it's a very useful tool to understanding trends and how things are developing for our workforce. And that still shows that 3/4 of staff regularly face time pressures at work, which are impossible to deal with. There's large percentages working paid and unpaid extra hours. I think something like 55% of staff regularly work unpaid additional hours. Work-life balance has traditionally been one of the biggest reasons for leaving. Chris talked about some of those in more details from more recent polling. But until we increase the size of our workforce and until we create the conditions to do that, and there are some positive movements in terms of applications to nursing courses and other courses, although those will take a while to capitalise on. Until we really address those things, the wellbeing initiatives, the bespoke sort of one-off offers and wider efforts from employers doing all they can for their existing staff, they're not going to go far enough, and they're not going to be a long-term answer.
Thank you very much indeed. Mike, do you want to add to that? You're muted. I think.
Turn off my unmute. Sorry. Yes. Yeah, I think that the main point for the well-being of staff right now is we would really share the concerns around burnout right now, and the intense pressure that people have been on through this period, and not just in hospitals where a lot of the press has been focused. This is right across all settings, all environment settings. If we think of a learning disability nursing team that hasn't, the other services that their service users maybe have normally accessed have been closed, so that puts extra pressure on their home environment. So as an example of how this has filtered all the way through. So there really needs to be a moment of how do we restore our services based on what is safe, rather than what waiting lists and what the political drive is around getting waiting lists down. Obviously, waiting lists include people who need care. That we have to be mindful of the fact that there is undone care at this point as well. But it just really needs to be a balance between clinical need, but also what is actually safe to deliver for in terms of having the right number of people to deliver that care with the right expertise in the right place, in the right frame of mind, in the right wellness to be able to deliver that care really well.
Great, thank you very much. Chris, would you like to add any additional words of wisdom?
Two thoughts from me. I think one on the scale of the interventions, which is a point we often make at IPPR, is if you look at the rhetoric that has come with COVID-19, it's often, from our own leadership, but also globally, it's often been compared to a wartime event. And I think, it has the people, the human cost, the social cost, the economic cost that kind of justifies that. But equally, the point that we often want to make is that wartime events have always needed to be followed by welfare, and that welfare is often focused on the people that were on the front line. So you've got Homes Fit for Heroes after World War I, you've got From Cradle to Grave after World War II, and we think Care Fit for Carers would be a decent way of framing this piece, which is somewhat a rhetorical flair and somewhat to stress the ambition that needs to come behind kind of grappling with these problems. I think the other thing I wanted to throw in was just on the safety point and the link Finn makes between the numbers that we have and then our ability to tackle some of the well-being issues that permeate, which is that the level of training and the cost of training, the qualifications that go into bringing forward a healthcare professional and the hugely trained staff and workers is such that there's often a perception that we mustn't oversupply these professions, that it would be outrageous. I mean, the common saying is it would be outrageous for there to be a situation where a UK trained doctor couldn't work in the UK within the National Health Service. And I think that's often a gambit that leads us to undersupply, that we undertrain. And we know that the UK certainly does struggle to fill its staffing needs. So I think we have to, in the future, post-COVID, thinking about resilience and security and sustainability and future pandemics and health shocks could come. I think we need to become more comfortable with the idea of oversupplying the health service, because that's how you create safe conditions. And I think that's how you address some of the burnout capacity points.
Thanks so much. And Sam, would you like to add any ideas of yours?
Probably just an extension of the point, which is, I think, again, we need to start looking more long term. We're brilliant at reacting in the moment. The emergency lights go on and we put in a number of interventions that short term absolutely make a difference. But long term, if we are, again, to create environments that enable people to be their best on a sustainable period, to thrive, to grow, we need to look more holistically at well-being, which is not just about individual health interventions. It's not just about recovery from the pandemic, but it's the point about we need to increase we need to increase capacity. We need to look at all our organisational systems, processes in a holistic way. Do they set people up to be their best? So I think we just need to encourage people to think more long-term and more holistic about wellbeing.
Superb, all of you. Thank you so much. Third question, what is actually happening on the ground? And what are the challenges, pitfalls in implementation? And Sam, perhaps you'd like to kick off on that one.
Thank you. So there have been, I think there are two areas that are very positive that the People Plan really shone a light on and helped accelerate, I think, some improvement in this space. And that is around new ways of working, new care pathways, doing them in a significantly different way than we have probably historically and traditionally done. And that includes, therefore, looking at more modern workforce approaches. So really encouraging us, and again, the pandemic did support this. I think it certainly enabled us to move at greater pace than we have done previously. Looking at competencies rather than traditional roles to plug gaps. Let's enable people to do their best work, to do the things that they really like. Let's be more flexible with our resources. So I think that's really key. The use of multidisciplinary teams, the use of working in partnership across the system, across social care, that I think we need to continue to build momentum on, but is a real positive. The use of technology, the use of virtual delivery, which we shied away from significantly prior to the pandemic, but yet now that is a single way that we can increase capacity and flexibility, which can only drive benefits of outcomes for patients and service users. Being able to access a GP, more frequently, more able than you could before. So there are challenges with those, because again, when we've run at pace at things, we perhaps haven't designed them thinking about all of the consequences. So let's think about digital poverty. If we're going to really embrace digital ways of working in our service innovation, we need to think about how we upskill as well digital competency across the country, enabling people to have more access. And flexibility. So we've seen across industries, across sectors, again, almost as a response to the pandemic, that flexible working, which may have been perceived as a bit of a perk, a bit of a benefit, is actually a really key requirement now, both for service delivery, but also for our workforce. And for us to continue as individuals to meet the demands of our equally challenging lives. I think one of us mentioned earlier, a number of people leave the sector because they're unable to meet the demands of work-life balance. 30% of new recruits leave after, be it health visitors or nurses, leave after the first 3 years of training for this reason, for some of these reasons. So we need to embrace flexibility whilst appreciating our complexity as a sector. It doesn't mean home working, so again, I think a lot of people now post-pandemic think flexible working equates to home working. We need some ward nurses to remain on wards, funnily enough, but actually we should have flexible working for all. We should consider what that means, and we should embrace what that means. And again, both of those things really push at what has been, I think, quite a traditional work model across the NHS. We need to be more modern. We need to have a think about how we, rip up the old rule book. But change in an area that is very risk adverse because of the nature of the work that we do is really tricky. So we need our leaders, we need our workforce to embrace trying things. They won't all work, but we do need to look at new ideas. We need to create the conversation that's the catalyst for let's try and embrace it. So again, it's commissioners, it's leaders all coming together. And I think one of the things that we talk about, but I'm not entirely sure we fully embrace, is listening to colleague voice. The people that can redesign our services are the people that are doing them. They're the people that make the decisions closest to our patients and our service users. And, we don't really actively embrace them. We do a survey, we do engagement surveys, but actually, how do we involve them? How do we unlock the secrets that they have? So I think combination there of huge opportunity, huge excitement to reform and transform services, but equally some watch outs, digital competency, digital skills, and embracing a change, a growth mindset in our leaders, and listening to colleague voice.
Thank you, Sam, for a highly stimulating contribution. I wonder if Chris might like to add to this.
Yeah, but only really to kind of agree with lots of what Sam said. I think the really fantastic point on the move to competencies as a way of thinking about workforce skills. We know that and published research with international research says the UK, particularly if we're thinking about where pandemic performance was good, use of skill mix during the pandemic, the way that we thought about that as a unit to create flexibility and extra capacity, that was one of the good things. People have developed new skills during COVID-19. The problem is we don't have any infrastructure to allow the progression and the embedding process that needs to follow. In fact, the policy push from recent years has been to downbanding. Taking skills and that would otherwise have been rewarded at a higher pay band and actually gradually taking them down. So we don't have really the progression and the pay infrastructure for some of that. And I think a challenge for People Plan, for policy more widely, is to think about how we can make sure that some of that's embedded in the way that, why it's for retention, because we know people do want progression opportunities and they do want to be rewarded for the skills and to be recognised for the skills that they've developed. So I think that's important. I think there is, on the wellbeing point, really good practice in some parts of the NHS. I think the Milton Keynes way that often gets talked about in terms of more empathetic approach on the ground to the workforce, really encouraging. And that means, it's simple things that recognise kind of feedback and that have done that process of listening and implementing. So taking away the extreme charges for travel and providing access to hot meals and making sure that people can have the breaks that they're due and hydration breaks and things that we know aren't consistent for some reason across the NHS. And I suppose as the last point, almost facetiously, that I feel like the 2019 election, we had this big debate, didn't we, about flexible working, because there was a policy around a 32-hour or 4-day week within the NHS, and the idea that could never be implemented. And I feel like COVID-19 has thrown the challenge back at policymakers to say, actually, we can't eliminate the potential of flexible working within the National Health Service. We need to actually think about how flexible working can become business as usual and what the sustainable models of doing that might look like. So it's very quickly changed that conversation, and I think there's a window of opportunity there.
Thanks very much, Chris. Mike, would you like to?
I won't repeat what others have said, hopefully. I think the one point I'd pick up, there was Sam touched on, is around for us the kind of unwritten implication of the People Plan's actions and the people promise and the overall intention of the plan really will stand and fall basically on the quality of how managers manage and leaders lead. And I'm not sure that there is enough investment in how to help people become good leaders and good managers. We know that we know the old adage of people don't leave their workplace, they leave the manager. But I think we need to go further in terms of investment in how people manage and how they lead. People tend to get the next job and then are left doing that job without additional support. We know, unfortunately, we do, in terms of our organisation, we see ongoing examples of kind of bullying and harassment and lack of civility in the workplace, but a lot of that probably comes from stress, the people leading under intense stress at times. So how do we develop our people? How do we support them to be able to manage and lead better? I just think that's really important. It's very easy for everyone to go, oh, it's the management. But managing people is actually, it's really tricky. Well, I find it quite tricky at times, because everyone's different and everyone has a different view on things, and how we get people going in the same direction and help them feel supported, I don't think is as easy a skill as sometimes we assume. So the plan aims to produce what it calls a movement for improvement. where systems work with staff and employers together to develop local plans. So I think the more that we can develop this culture of just talking about things and people feeling included and part of the same thing rather than being done to, I think that would be a really positive step forward. And I think hopefully with the development of ICSs and the white paper, that's a moment we can seize a little bit as a new thing that we can work together and moving forward. But that emphasis on how we help people lead and manage, I think is an important one that we should focus on.
Thanks very much, Mike. And Finn, would you like to add your own thoughts on this one?
Yeah, I think most of it's been said. I'll just make a few quick points and then pick up on something Mike was saying there. I think Sam was talking about flexibilities, and we absolutely have heard from trusts that there have been some really actually positive working practices during the pandemic and movements towards flexible working, and there is a good piece of work, ongoing work on this happening sort of at central level through NHS England and others to try and convert some of those flexibilities into, longer term practice. So you mentioned several of them, but I think certainly working across disciplines, working across organisations, which oddly is really difficult for staff at times, and some of that is due to basic things like contractual awkwardness and sort of legal frameworks that aren't sort of readily available or practiced throughout the NHS. So we need to convert those into things that can happen in the longer term. One of them is less duplicative bureaucracy, and this is something that I think has helped both managers and staff. There was a poll earlier in the pandemic from the BMA showing a huge level of satisfaction with reduced paperwork from doctors. I mean, I know some of that is obviously just a necessity when there are more important things to work on during the pandemic, but we need to try and keep some of those. A lot of good things happening on the wellbeing side as well. Chris makes the right point that we need to make sure they're more consistent across the NHS. He talked about refreshments. There's a lot of work happening on sort of rest areas, resilience hubs, sort of wellbeing spaces. I'd encourage people to find a Guardian article from, I think, last weekend, which focused on some of those initiatives that trusts are putting in place at the moment, that I know we contributed to as an organisation. But the point from sort of Mike about leaders as well, and I think he's absolutely right that those are stressful jobs too, and I think we often forget that. We often forget that NHS managers have bosses too. They have bosses at NHS England who have bosses at the Department of Health and in other parts of government, and the pressures on them to meet short-term sort of operational targets, reduce waiting lists. I think there is an appreciation through the People Plan and through its sort of earlier versions, perhaps more so, or equally so, that we need to shift the focus for trusts and for other organisations in the NHS to a more people-centric sort of vision when we're looking at improvements, rather than just looking at short-term financial and sort of operational delivery targets. If our priorities are with staff, then we will spend more time on that. We will prioritise their well-being ahead of sometimes the need to meet these short-term targets and sort of the severe pressure that comes down from above there. So really just agreeing with Mike and emphasising that is a shift that is needed in the medium to long term.
Well, thank you all for your very insightful contributions. The final preset question is, what priorities should be focused on to make the NHS leadership more inclusive? And I think, Mike, you're the ideal one to start off with that one. You're muted.
That's all right. I'm just scrabbling around to the button. Sorry. Sorry. Getting confused. Yeah. So in the context, I think starting in the context of the pandemic, I think a lot of our members, so from nursing staff, but I'm sure it's other areas as well, felt that their kind of psychological contract with the profession and their employer changed a little bit. I think early on with the issues around protective equipment and poor quality risk assessments, as built on feelings in some areas of unaddressed issues around systematic kind of discrimination or feeling a lot unsupported in the workplace. Adding onto that the extraordinary levels of stress and moral distress, it's at this moment in time, we kind of need a new starting point, a new psychological contract maybe with our staff, with our people, and I think, you know, the people plan really does acknowledge the importance of inclusion in workplace practices and good cultures in the workplace in order to attract, retain, and kind of engage staff and people to work to their highest level of productivity over a sustained period of time. I think probably when it comes to inclusion and NHS leadership inclusion, I think we could go further. I think we could be more deliberate about it. We could see the development of leadership management competencies around inclusion. So we could cover things like ensuring that how we redesign systems and processes mitigates the impact of bias and discrimination across the system and at institutional level. And we need to be open to learning about this and to be open to the fact that it exists. I still think whenever we see res data published, there's still an underlying, but does it change enough quick enough? I mean, there is positive movement there, but it feels as though we need to be braver and have more courage around this, to talk about it a bit more openly and a bit more honestly about things. So helping set some competencies around what more inclusion leadership looks like might just set some standards and help people kind of reshape what they're looking at, and how their own performance needs to change or their own views need to change on things. So then we could also then perhaps look at some metrics around that. We do have the res data, but can we focus development of metrics that help organisations to effectively map out their journey towards the creation of inclusive workplaces, ultimately to improve the lived experience of staff and to make sure that we're getting the most out of all of our people and we're not leaving huge potential in areas, in roles that where they can't flourish, where people don't feel a sense of just culture, or that they can learn and grow, because we need to get the best out of everyone. So I think we certainly talk about it more now than we did ever before, and that's really positive. But I personally, I think we can be a lot braver and a lot more open about it. And actually, we need to be able to challenge at all. Again, it goes back to leadership all the way through our leadership systems. We need to be able to challenge the small incivilities, the small moments of maybe just, you know, honest ignorance, if that is a thing, so people don't feel scared of doing the wrong thing or scared of saying the wrong thing. We just need to try and be more open about things.
Thanks very much indeed, Mike. Some very thought-provoking and thoughtful suggestions there. And would Sam like to add her thoughts on this very important subject?
Yeah, I think again, just more builds really, but equality, diversity, inclusion, it's, you know, it needs more dedicated attention, but it's also not something that can change overnight. You know, it needs, again, a long-term approach. It needs a system-wide approach. And we tend to be, again, we kind of pivot and kind of have focus based on the data that we see in the moment. Again, I think we just need to pause, we need to have time to think, and we need to come together that really drives a different approach here. And I like Mike's words, you know, bold, brave. We need to have more ambition in this space, and we need to hold each other to account in a much more robust way. Priorities for me: education. We have a role again as an employer. We also have a role in the communities that we deliver care to. Leadership, we've talked about, recruitment and really making some real inroads in that space. And again, service redesign, you know, that we need to make sure that how we respond doesn't kind of add further burden or further challenge to a number of the health inequalities that we know exist. So I think it's right that we do hold ourselves more accountable for this, and this will only ever change with real concerted, committed and sustained leadership, accountability and responsibility.
Thanks very much, Sam. Finn, would you like to add your ideas?
Yeah, sure. So I look at this question mostly from the race equality perspective, I think, because it has been such a concern of NHS leaders and NHS staff over the past year, and obviously following the sort of well-publicised events, including the death of George Floyd and Black Lives Matter protests across the globe. But you know, I think it's important to stress how that was felt in the NHS as it was through wider society, and how it has really translated up to board level, the level of priority that staff put on, you know, improving race equality in the NHS. And the NHS hasn't had a great record here. Mike mentions the RES data, and there are some improvements. For example, board representation for ethnic minority people has, you know, improved slowly, but not enough. I think we need to sort of all be honest about that and ensure that there is a system-wide understanding of the limitations and the lack of fairness in certain areas, particularly in regards to the workforce. And we do need to be bolder. I think you know, one of the more depressing charts that I see on an annual basis is the level of representation of ethnic minority people in the lower bands, and then sort of cratering down for higher pay bands. And, you know, from a point where we have about 25% of band 5, which is where a newly qualified nurse would start, are Black, Asian or minority ethnic, and then down to about 7% at VSM, very senior manager level. That is quite depressing. That's something that we need to be more proactive on. You know, there is a public sector equality duty for organisations to take due regard to eliminating discrimination in their practices. I'd encourage people to look at you know, some of the work of Roger Klein, who initially wrote the Snowy White Peaks report on the sort of whiteness of NHS leadership, for lack of a better way of putting that. But one of the things that he points out is we need to stop doing things that don't work so much as well. So we can't just decide when we see poor statistics, you know, that everybody is going to take unconscious bias training that will solve everything, because that's consistently proven not to be the case. You know, we need more proactive policy interventions. And I think in this country as well, we need to be a bit less squeamish about affirmative action, positive action, I think we call it here as well, and whether we have the legislative environment to actually allow for those sort of bolder interventions. Looking to other countries and other sectors where there have actually been improvements as well. You know, the other part of it is ensuring a more inclusive culture throughout the workforce, as inspired by managers, which other speakers have spoken about equally too, because that, you know, staff experience side isn't getting better necessarily as well for ethnic minority staff too.
Thank you very much, Finn. And Chris, would you like to add your own words of wisdom?
Yeah, it's a strong agreement with others' points, really, and particularly like Finn, your point on stopping doing the things that don't work and beginning to do the things that do. I think there's a good evidence base that some of the kind of classic and I suppose the kind of places that people might instinctively think, I need to do something on inclusion, are not quite proportionate to the problem, but there are some interesting ways to tackle it. So one example is allying schemes have a good evidence base and help put people that are less marginalised, less discriminated against in a position to call out discrimination and support colleagues. And that's, you know, that's indicative of some of the steps that can be taken. I think one thing that might help, particularly a National Health Service, to take some of this action is to appreciate the health consequences, I suppose, of discrimination and unequal employment outcomes. There's a long history of evidence on what it means for the health of, you can think about it on any line of inequality, socioeconomic status, race, gender, whatever it might be, but the health impacts of unequal employment are severe. So the Whitehouse study shows that decades ago. It's been repeated ever since, and the same applies within the NHS. So I think if the NHS wanted to lead in a public health approach to its inclusion discrimination issues, might be one that helps it achieve that. And it's a wider ambition, isn't it, to make the NHS preventative by default, and a true health service. So that's a plank in that puzzle, I think.
Well, thank you all very, very much for your very insightful, thoughtful, and well-informed contributions with such superb, widespread experience. So I think it was a very, very useful session. There is time now for comments and for questions. I see across the bottom of my screen there are quite a lot of chat and comments, and some from my good friend in the House of Lords, Baroness Udin. But the organisers are going to kindly organise the way, because it's impossible to make sense out of chats that keep going across the bottom of the screen to do justice to them. So I think our wonderful organisers are going to pose the questions, and then people who would like to volunteer to answer them, I will try to respect your priorities. Thank you. Over to our wonderful organisers for questions.
So I've got the power. So I've been sent some of the questions. So I'll go. But okay. So we've had a question, probably linked to that last debate actually, which says the RES, our workforce race equality statement, and the staff survey results are still showing that we're not providing an empowering and caring workplace. What must happen now?
Fine. Who would like to lead on that one? I'm not bossy. Volunteers to lead on that one? Okay, well, I'm looking along the lines. Nobody's volunteering. Chris, how about you? You're first on my line of vision.
Well, I think a lot of it comes back really to the final question of the panel discussion. But one thing I'd throw in extra is that there are certain things that keep very senior managers and leaders within the healthcare sector up at night. And those things are probably, if we're honest, cancer performance, probably A&E waiting times, probably the rating that you get overall from the CQC. And some of those are useful, some of them we know are less useful as targets and as indicators of performance. Now, I think if we really want to take action on discrimination, on inclusion, on inequality within the health service and within employment within the health service, then I think we need to work out ways to escalate the prioritization that it gets to that top tier, to that platinum tier of things that genuinely impact the reputation of a provider or the performance of a leader, not just in trust, but in NHS England head office as well. So that accountability line, I think, needs to be strengthened. There's an opportunity there, isn't there? There's a societal movement towards calling out these kinds of injustices, and there's a choice, I suppose, a fork in the road of leading that or playing catch up with it. And I think an organisation as beloved by the public in all polling as the NHS should probably choose to lead that charge.
Thank you very much. Mike, do you want to add anything from your experience?
I might just cut in ahead of Mike, because I think he had a bit of a system challenge there in the question. So I think so it's about technology, you see, but it's so the question was around how do we create empowering and caring workforce. And I think that the leadership debate that we were talking about earlier is so very key here. So having the right leaders that are there to provide challenge and support, and are confident in their ability to really support and drive change through their people and respond to people and empower them to make the changes that are important in their day-to-day role, I think is really key. So I think I would take us back to the conversation around how do we truly transform, develop leaders for the now and leaders for the futures. What are those competencies and what do we need? I think that's a really good debate that we need to have.
Excellent. Is Mike back with us now?
Yes, sorry, I just did miss the question when it came through. I do apologise. It's a really interesting question, actually. How do we, how do we make people feel better, for want of a word, in their workplace? But actually, one of the things we're looking at is, I think people in their workplace have more influence on their workplace than I think they realise that they take advantage of. And certainly what we're looking at as a college is how do we help people do that moving forward? How do we help groups of people in a workplace solve, rather than looking to their union to solve it? How do we work with people to help come up with the solutions themselves and empower them to work in their own employer, to work with their employers, to actually solve some of these problems? Because I think one of the biggest frustrations people feel is, as I mentioned earlier, when people feel done to, when things are done, when in your own workplace you can see no logic behind a decision, and that can be as simple as having some lockers removed where you used to be able to put your coat, or it can be it could be a whole service redesign. So how do we help people in their workplace feel that they are part of the decision-making process, that they are part of the way forward in any given organisation? And I think that has to come from leadership. Well, it comes from the people themselves feeling empowered, but it also comes from leadership being open to that as well, and giving some permission for that and showing that that's a good thing. So a lot of it that does, whilst it's workplace, people in their own workplace, it also links back to I think the point Finn made earlier around the stress within a system, the pressure within a system does come from very, well, however distant it is to the actual person delivering care, that pressure filters through a system, and there is responsibility on really senior people within our healthcare system to role model and set that tone as well.
Great, thank you. And Finn, do you want to add something on this question?
Yeah, I think I just, again, agree. I know the point about staff voice, I think the People Plan does have a bit of a focus on this. For example, an action to ensure that staff networks are able to contribute to and inform decision-making processes. And I think, to go back to the sort of equality, diversity, inclusion point as well, we did see a lot of positive developments through BAME networks, excuse the use of the term BAME, but we need to build on those, and we need to make sure that best practice is shared, and this is a common refrain across the NHS, but creating spaces to ensure that where something has worked well, for example, where an organisation has actually improved its res data, whereas many others might not have, what are they doing right? Can we ensure that we have this conversation, with leadership from the government and its arm's length bodies to make sure that, we really capture those things. I think the final point I'd make, Mike was sort of talking about unions in the NHS and ensuring sort of local sort of action, local inclusion. We shouldn't take for granted, I think, that the NHS as a sector probably, others might disagree, but probably has better links between staff, between unions and management than many other sectors, not just in the UK, but around the world. We need to take advantage of those and sort of build on the social partnership kind of approach that we have seen improve things over time, where sort of employers and their staff networks and union representatives can come together.
Great, thank you all very much. Sam, the next question you've managed to distill out of the abundance of questions.
Yeah, we've got lots, and lots are coming through, but this one we haven't probably touched on yet, but very important. So from Liz Harris, increasing the number and supply of the workforce is required to ensure that we meet patient and system needs. But how do we solve the problem of a lack of clinical placement currently available, or currently being experienced by the majority of some AHP students? Mike, I think you might want to start. maybe with student placement generally?
Well,
maybe.
Yeah, I mean, actually, in a former role for about 4 years, I was lead Birmingham City University for the Department of Practice Learning, which looked at placements across all the professions in the university, health professions in the faculty. It was the most terrible job I've got to be honest. I absolutely empathise with everyone facing this challenge of student placements and student capacity. What I guess the solutions are, if there were easy solutions, we'd have found them years ago. Ultimately, I think in my experience, where there can be obviously close partnership working, a close joint purpose between partner employers and education providers, where there is a kind of a joined up will to support students and develop placements is obviously really important. I think there is a piece of work to do on helping our existing staff and people, helping them not prioritize probably isn't the right word, helping them see the importance of supporting students. I think if you talk to any group of students, they will always say, this placement I really enjoyed. It was absolutely fantastic. I learned lots and I absolutely could not stand this placement and I nearly felt I was going to leave. And you can compare the two placements and you can look at all sorts of metrics, but actually the big difference is how people were to them, how kind they were, how they approached them. And I think that cultural piece again is really important to how we keep students, how we retain our students and keep them in our workforce. In terms of how we increase capacity, I think we have to absolutely retain our workforce who are going to look after our students. I think it is all linked in terms of how people feel in their old roles. From a nursing point of view, our biggest concern is, a considerable group of the nursing population are approaching retirement age. Now, historically, people wouldn't necessarily just retire as soon as they can, but I think there is a real risk at this moment in time they will. So again, it's difficult to look at one bit of the workforce jigsaw without the other. But I think absolutely retaining the people we have, building really close relationships of mutual benefit in terms of how we provide placements for students, I think are two key areas. No magic bullet there, I'm afraid.
No, I just to build on that as well. So we're working very closely actually as an organisation with Health Education England at the moment in what we, during the pandemic, again, what was forced for us, we continued a number of our student nurse placements virtually. Now, that's not, you're never going to have a virtual programme that is solely virtual. So we have to kind of work out what's the mix, and we'll look at blended opportunities for sure. But that is, I think, a very tangible way of how we can also help where it's appropriate to increase availability. So if we can get a bit of a blended approach in terms of what could we do that's legitimate virtual versus, actually there is something that you need to do hands-on in the service in front of a patient. So I think, again, looking at some of those creativity or creative ideas would also help us, I think, there.
Excellent.
Shall I go for another one? Should we go for another one? Right. Okay, again, slightly different again. So what impact do the proposals on the white paper on health and social care integration have? What does the panel think of doing that now when staff are under a lot of pressure from responding to COVID and delivering the vaccine? Is it an appropriate time to go ahead with a major reorganisation? Who wants to go first? Chris?
Yeah, happy to jump in. I mean, I think two things. One is that no is probably the answer. It probably isn't the right time to engage in structural reorganization. I think we, the line of questioning has to be how would structural reorganization help get through the inevitable and massive, to be fair, backlog of care that the National Health Service now faces through 2021-22, and it seems unlikely that in that instance it does that, and also how it will benefit, kind of patient outcomes directly from there. So I think probably the timing is wrong. That's not to say actually that the direction of change is wrong, just because the timing's wrong. I think, and a move to integrated care to population health, there are definitely signs from within the pandemic that that's more resilient in the long term. So maybe the direction's right, but the timing's wrong. And I think there's, from a people perspective, there's an interesting implication from the reforms as set out in terms of how we approach recruitment, and particularly actually how we approach recruitment and progression within social care. I think if there's a genuine hope of integration, and one of the key tests of that would be not just whether there's the ability, for cross-sector working between social care and the NHS, not just whether social care workers have the ability to progress through the NHS, but of course whether the NHS has a trajectory into social care as well. So in terms of how it affects recruitment, I think the main implication on people is that it throws up that growing movement towards better professional and progression integration and pay integration between the social care sector and the health sector itself.
Who else might like to add their experience and thoughts?
I'm happy to jump in. I think in terms of the timing, it is very tough timing. I suppose there's an argument that it would be difficult at any point. I think the key now is to ensure that the process which takes place between now and legislation passing involves as much engagement and collaboration with the sector, with the organisations represented here, like the RCN and others, as possible, which is a challenge given the sort of timeframes that the government is working to push it through. I think yes, agreeing to some extent on the right direction of travel. I think the move towards more population based care, of course, that's absolutely right. And I think the progression of systems and how they've developed as organising functions of the NHS, and that's positive too. The devil will sort of be in the detail on how effective the current provisions are, and again, that all needs to be worked out over the next couple of months. I think I would just say again, though, the point has been made a couple of times, there's no real answer for social care within these proposals. It's just, it seems like constant passing of the buck really on social care from consecutive governments, consecutive administrations, and it's pretty disappointing not to see that included as part of the proposals.
Anyone else like to add a thought on this important question?
I'd just add that I would kind of agree with those points. Actually, it feels as though it's needed to revisit how the system is and how we as it states, how things are integrated better and work better across a whole system. The when is a different question in terms of where we are right now. But I mean, I certainly think that the piece in the legislation around workforce accountability, it's never going to be too soon to get that more embedded as a clear accountability of who and where is responsible for that. It possibly doesn't go far enough for us at the minute in terms of the draft, but it's good that there is an opening there to talk about that, because again, I feel that all roads lead back to people in terms of safety of what care we can deliver. But I totally agree with the point around it doesn't address the social care issue. And I think if we saw anything so vividly identified through the pandemic, was in the initial kind of weeks of the pandemic, when we saw just as an example, that the supply issues around protective equipment, it really highlighted how fractured our system was in terms of, in a moment of emergency, that it wasn't a slick system. It absolutely highlighted the fractured nature of having thousands and thousands of different employers, all kind of working slightly different within that system, and who's got the overall lookout for that in terms of how people are being cared for.
Thank you very much, Mike. Should we move on to the next question, Sam?
We can do. There have been a number of people who have volunteered for the vaccination programmes and more widely returned to the workplace to assist during this time. How do we harness this opportunity to retain some of these people and provide a learning and development environment to allow those people who want to move into health and social care to take up the opportunity? Is there a national approach to this?
And who feels absolutely bursting with enthusiasm to be first on that one? Chris, you've got a big smile.
The risk of smiling. I think there's definitely, I think that way of phrasing actually of harnessing the energy and focus on health and care and people wanting to come and can contribute to the health of the nation is probably one of the ways. I think a specific area we can do a lot more with in healthcare is apprenticeships, which are a difficult thing across the whole of the economy, with particularly the technical the technical problems around things like apprenticeship levies and a whole ball game over there. But I think using apprenticeships to bring people that want to come into that profession, maybe because of voluntary experience, that's one avenue of doing it. I always think it's worth, having a quite balanced approach to this, though, because I think there are remarkable examples of voluntary work. There's huge benefits that can be brought, but I also think that there's a balance with to what extent the delivery of the National Health Service reflects a charity or voluntary sector style model. So we've obviously seen during 2020 a big uplift in voluntary work. We've seen a massive uplift in terms of charity donations going into NHS charities, and I think that can be very positive where it doesn't exclude the proper level of state funding, state provision, and it's not in some way a replacement for the kind of revenue and the kind of sustainable funding and workforce resourcing the NHS needs. So huge opportunity, but yes, that one slight counterbalance to that.
The signs of time are running out very quickly, unfortunately. If nobody else wants to add a response to that one, I think you've probably got time for one more question, Sam.
Okay, I would totally echo that. I think we need to find a way of enabling people to provide contribution in any way they can. So I think as well, the more we are able to approach more flexible working arrangements, the fully utilisation of the bank, I think that the better. So I think we do need to do more to unlock the different types of resourcing models that we've got available. It's really hard to choose like a kind of a final question, oh, sorry, pressure. Right, so I'm going to go for somebody who's quoted Richard Branson. So train people well enough so they can leave, treat them well enough so they don't want to, is Richard Branson's quote. How far off does the panel think the NHS is from achieving the aspirations of this quote?
Any volunteers to lead the way?
I'll start on that one.
Thank you very much.
If you like. I think that is a very good quote in terms of what we should all be aspiring to. How far off the NHS? I mean, the NHS is a huge employer, and so there's lots of people who work for the NHS. And I think from our point of view, when we look at nursing as a profession, and there's considerable vacancies that we know about. We have all the issues that we've highlighted around workplace environments and cultures and things like that. But I feel we are talking about that more than we ever have done before. And there's not a blanket, it's terrible everywhere. There's not a blanket, it's brilliant everywhere. I feel that there are other barriers that we could remove that would enable people to deliver the best care that they can, that I think ultimately is people's biggest stress when they can't do the job they want to the best of their ability. And I think we have to go back to the number of staff, and some of that is the key kind of driving policy decisions from government about how they fund students or don't fund students, and then nursing, well, workforce pay. We haven't really talked about that yes, but when we surveyed our members last year, we had a biggest response we've ever had to a survey, and this was right at the start of the pandemic. A third of members were saying they were looking at leaving nursing, and pay was the main driver in that decision. Now, whether that comes to fruition that they do leave or not, they were thinking about it right then at the start of the pandemic, and pay was the main driver. And that was a shift from previous surveys. It had always been about the main issue was staffing, numbers of staffing. It was still number two, but it had shifted to pay. So for me, for the NHS or any employer to meet that quote of Richard Branson there, they've got to remove the barriers, do everything they can to remove the barriers to people delivering the best care that they can. And at the moment, the number of people around them and the value they feel in their work linked to pay are the two big barriers right now that have to be solved.
Thank you very much, Mike. As this is the last question, would other speakers like to make their contribution either directly related to this question or by way of concluding the ideal thoughts you'd like to leave with people? Who should I go to? Finn?
Yeah, I think the 2 points made there, and we sort of talked earlier a bit about actions as well. The pay offer needs to be better than what is currently being sort of mooted, and needing to keep in mind that 1% figure is also just a piece of evidence from one party out of many parties in an independent review process. So putting that in perspective, and those independent bodies should make a decision, and hopefully it's a lot better than that. The workforce numbers, it is the biggest barrier. We'll go back to it, but it is the biggest barrier. We had 100,000 vacancies in the trust sector alone before the pandemic started, and many more in primary care, and over 100,000 in social care. And as Chris pointed out earlier on, that's just based on the levels of capacity that we were sort of planning at the time, which I think have shown to be short by what's happened in the pandemic, to put it mildly. So we need a fully costed and funded long-term workforce plan, and these are things within the gift of government and Parliament to pass laws to enable that to happen. And I suppose back to the point on social care as well. I won't sort of belabor the point, but if we're going to really talk about integration, let's make it actually happen.
Thanks very much. Sam, response to this question or final thoughts?
Yeah, thank you. I echo the barriers that have been mentioned, so I'll just focus and reinforce the opportunity too. I echo the point. These conversations are super helpful for raising the profile, raising the agenda, making sure that we're talking about the right things. So it's good that we're doing these. We need to continue to do them, and we have a huge foundation for future success. We have a workforce. If you look at, I sit as a Chief People Officer. What do I want? What are my enablers? It's a workforce that is passionate, that is committed, it's highly talented, they are dedicated to the cause, and that's what we have across all providers of NHS services. And that's who the workforce is going to grow from, learn from, thrive and survive from. So I think that's really important for us to remember. We need to listen more. We need to use the skills and knowledge that we have more to unlock and build our future from. So leaders, we've talked about today, key priorities for me is developing leaders for the future, being really clear about what our competency approach is for the future, having to think more flexibly about roles, and with that pay, the appropriate pay for people, and focusing on wellbeing and culture are real key themes for us.
Thank you. That very upbeat concluding contribution. And Chris.
Yeah, I agree with others, and I know Caroline, you wanted some practicals coming towards the end, and so I wanted to focus my concluding remarks on a piece of research that IPPR are looking to do in the future, and it's really taking Finn's point that we need a fully costed long-term workforce plan and trying to develop what that might look like. So we, I suppose, feel that workforce crises happen cyclically. We have almost the same boom and bust cycle of workforce crisis that the economy has. You can trace them every 20 years or every 30 years, at least major crises. So the work, the research that we want to do is how do we break that cycle. We're recruiting practically an assembly of people that are working in health and care careers, or that are managing conditions, or that are providing informal care. Of course, if that meets anyone in the audience, or there are workforce managers, directors in the audience, we'd love to hear from people in your network. And Sam, Mike, Finn, sure, there are people in your respective networks as well. But I think if others, if there isn't a really long-term workforce strategy coming from government, from policymakers, I think providing one for them is a useful exercise.
Well, thank you all very much for precision timing as well. Obviously, from me, there comes a really heartfelt congratulations and thank you to all the speakers. I keep getting very positive messages from my colleague and friend in the House, Lord Baroness Udin, who has put in several messages of great appreciation, which I totally endorse. And I would just like to say I've been profoundly grateful for the amazing width of experience, the knowledge, the information from such different sources. And thank you very much for your extremely useful, informative, and I'd say at times, well, not at times, I'd say overall inspirational contributions to this very important conference. I'd like to thank all who have attended, all the participants, those who put in questions and chat show. I see there's a lot of things I'm going to enjoy looking at in due course. But thank you to everyone who's taken part. And of course, thank you very warmly to Whitehouse and Virgin Care for organizing this complex conference so superbly well. So thank you so much. And obviously, may I just point out that it's not the end, that Virgin Care is publishing a report on this subject, which will be shared with all attendees. And I'm also asked to pass on to you the invitation for people to contact Whitehouse with any questions or comments you might have. So this is not the end, but all good things do have to come to an end. And as we come up to the final minute, sadly, it's time to end this conference, but I think we'll all go away enlightened and encouraged by so much in the way of thoughtful contributions, enlightened by the information we've received, and hoping to keep in touch. So a big thank you to everyone, and virtually at the stroke of 12, which I need to finish. Being a nurse, I'm used to keeping to time. I'm sure all the professionals here are, but sadly, we need to say au revoir. And I leave you with a very, very big thank you to everyone. Bye-bye.